Senate Health, Education, Labor, and Pensions Committee will please come to order. Today we are having a hearing on the fentanyl crisis that is devastating our communities. I will have an opening statement followed by Senator Cassidy. And then we will introduce our witnesses. After they give their testimony, senators will each have 5 minutes for a round of questions. And again, while we're unable to have this hearing fully open to the public or media for in-person attendance, live video is available on the committee website at help.senate.gov. If you're in need of accommodations, including closed captioning, please reach out to the committee or the Office of Congressional Accessibility Services. Last week, back in Washington State, King County declared fentanyl a public health crisis, and it is painfully obvious why. This year, King County alone has lost over 270 people to fentanyl overdoses. That is an increase of nearly 50% from last year. That's more than one fentanyl death every day, and that's just one county in my state, one corner of our country, which lost over 100,000 people to drug overdoses last year. That is an all-time high. And that number doesn't just represent a grim record, it represents so many personal tragedies, so many families that are shattered by the loss of a loved one, parents, caregivers, and increasingly teenagers. Now, there's no question we had a mental health and substance use disorder crisis on our hands before the COVID pandemic. But there's also no doubt things have gotten so much worse due to the trauma of this pandemic, and so much more deadly with the sharp rise of illicit fentanyl in recent years. That's because fentanyl is up to 50 times stronger than heroin and 100 times stronger than morphine. 2 milligrams can be a lethal dose. From April 2020 to 2021, synthetic opioids, mostly illicit fentanyl, were responsible for nearly 2/3 of all overdose deaths. And the recent rise in fentanyl overdose deaths has also reflected the painful systemic health inequities we still need to do so much to address. Black communities, as well as American Indian and Alaska Native communities, have suffered a higher increase in overdose deaths than other demographics. There's also been a deeply alarming rise in young people dying from overdoses. In 2019, over 250 teens died from illicit fentanyl. Last year, we lost almost 900. Think about that. Fentanyl deaths for teenagers more than tripled in 2 years. My heart goes out to every family touched by this crisis, and I've heard from many of them. People who lost a loved one after a long, hard struggle with addiction, and those who lost a loved one suddenly to a counterfeit pill laced with a lethal dose of fentanyl. Our communities are doing everything they can to fight this, but they need help from the federal government to stop these dangerous drugs at the source, cut off supply lines, and importantly, get these kids and their families the help they need. And the way we do that is to support families on the ground through robust public health efforts and better access to mental health and substance use disorder care. When it comes to cutting off the supply of fentanyl, FDA has been working to crack down on counterfeit drugs being sold online, something I want to see them continue making progress on to protect our youth. And the DEA is working to seize fentanyl-laced pills before they can end up in our kids' hands. I've been pressing President Biden on this the same way I pressed the Trump administration. And we are seizing more fentanyl-laced pills than ever before, and I appreciate the hard work that's going into that. Our law enforcement and first responders on the ground are really working to rise to this challenge to stop these deadly pills and save lives and ensure people can get the care they need. But when I talk to police officers or fire chiefs and first responders back in Washington State, it's clear we have a lot more to do to build on the progress we're making, cut off the supply lines that produce these dangerous drugs, and prevent them from ever reaching our communities. Drug trafficking is a serious problem, and that's why Democrats continue to work with Republicans to provide significant funding for border security and drug interdiction. But let's get one thing clear. We need to be taking this seriously and having real conversations about how we address the national threat of fentanyl use and supply, not playing politics, not scapegoating, not fear-mongering, not attacking refugees and immigrants with proposals that are based more on xenophobia than on what will actually work to keep people safe. That's not to say we cannot talk about accountability, especially for opioid manufacturers who fueled this crisis to line their pockets. There were enormous corporations that knew just how dangerous and addictive these products were and yet decided to ignore the risk for patients, market these pills aggressively, and flood our communities with opioids. We absolutely must hold these companies accountable for padding their profits at the expense of countless lives. Of course, stopping the supply of illicit fentanyl and holding companies accountable, which fueled the opioids crisis, is critical. But we really have to tackle this challenge from every angle possible. And with that in mind, we have a lot more work to do to help our communities get people the mental health and substance use disorder care they need. Right now, less than 10% of people who need substance use disorder treatment can get it. And care is even harder if you are Black or Hispanic or American Indian or Alaskan Native. The painful reality is that most people who died by overdose didn't get any substance use disorder treatment before they passed away. That is unacceptable. We need to do better. A big part of the problem is our mental health and substance use disorder workforce has been woefully overstretched and understaffed. I've said this before, but it's so important to understand if we're going to get our arms around this. Almost 130 million Americans live in areas with a mental health care provider shortage. Essentially, they don't even have one mental health care provider per 30,000 people. In Washington, our mental health care workforce is only able to meet 17% of our state's needs. If we're going to turn the tide in the fight against fentanyl, that's going to have to change. We cannot lose sight of the fact that a strong public health system and easy access to treatment for everyone are some of the most powerful tools in our arsenal. We need to make sure every community has a robust public health department with the data needed to track overdoses, stop spikes, and the ability to raise public awareness about rising threats like counterfeit drugs laced with fentanyl. And we need to support programs on the front lines in our communities that are focused on prevention, treatment, and recovery support. I've fought hard to invest in our communities to expand mental health and substance use disorder care through HRSA, which is helping build our mental health and substance use disorder workforce in our rural communities, through federal grants, which have helped set up dozens of new treatment centers across our states, and in the American Rescue Plan, which included critical funds for this work. But to talk to anyone on the front lines of this for 2 seconds and you'll understand we have a lot more to do. Talk to the fire chief in Seattle who told me a few months ago they respond to 4 overdoses every day. Talk with the University of Washington researcher who told me how 80% of people who could benefit from services to keep them alive can't access them. Talk with the nurse in Everett who told Secretary Becerra about how there are just not enough beds to get people treatment, and the mom who told them about how she lost her job, her house, and her child while she was struggling with fentanyl addiction. Talk to Jason Cockburn at the Second Chance Foundation in Everett, who's spoken about the challenge of trying to get kids the treatment they need, or the many people who desperately tried to help him find an open treatment bed for a 15-year-old earlier this year, calling contacts, posting to Facebook, all to no avail. It's so clear that leaders like Jason, who are on the front lines of this crisis, need so much more from our federal agencies and from this Congress, more when it comes to getting fentanyl off the streets and more when it comes to getting people the health care they need, which is why I'm as determined as ever to continue the progress Senator Burr and I are making on a bipartisan package on mental health and substance use disorder. We need to support the programs on the ground in our communities that are already doing life-saving work to identify people who are at risk and prevent substance use disorders in the first place, to get people treatment, and to support people in recovery. And we need new programs, especially when it comes to addressing the new challenges we are seeing with fentanyl and with heartbreaking increases in overdoses among young people. So I'm going to continue to press for us to advance as expansive as a package as possible, as quickly as possible. And I believe that we can do it because we've done it before. In 2016 and again in 2018, Democrats and Republicans worked together to pass some of the most comprehensive legislation to respond to the opioid crisis in our country's history. That has made a big difference. That legislation has undoubtedly saved lives. But I've traveled to just about every part of Washington State to talk about this crisis, from Everett to Seattle to Longview to the Tri-Cities to Spokane and more. And the challenges that we are dealing with today are not the same challenges we faced in 2018. So now it is on all of us to build on the bipartisan progress we've made, and it's painfully clear our communities cannot wait. They need us to meet this moment with serious action and life-saving support for families. With that, I will turn it over to Senator Cassidy for his opening remarks.
Thank you, Madam Chair, and I thank Ranking Member Burr, who allows me to lead this meeting. As a physician, I took care of patients with addiction, but it doesn't take a physician taking care of those with addiction to know that we have a fentanyl crisis. Everyone here and everyone watching knows of someone who has died or who has suffered from addiction related to opioids. If you read of a young person who dies as a teenager or in college, most often it is related to a drug overdose. And you think about the tragedy of that child whose whole future was before she or he, and now it is ended, affecting not just their life, but all those generations that would come after them from that wonderful person. It is incumbent upon us to address this issue. Now, the statistics. Fentanyl is killing over 200 Americans a day. In 2021, we saw the largest annual increase in opioid deaths in 50 years. In the 35 years between 1979 and 2016, 600,000 Americans died to overdose, and 100,000 died last year. I'll speak of my own state. Louisiana's drug overdose deaths hit a record high of 2,100 in the 12 months leading up to March of 21. Overdose mortality increased statewide by over 56% from 2020 to 2021. New Orleans was up 51% in 2020 with 365 overdose deaths. Jefferson Parish up 69%, St. Tammany up 35%, and St. Bernard up 64%. And we know the cause of this, it is fentanyl. Illegal fentanyl and fentanyl-related substances are flooding into our market from our southern border in unprecedented amounts, with the bulk of this ultimately originating from a handful of manufacturers in Wuhan, China. Fentanyl accounted for 64% of the 100,000 overdose deaths last year. 2 out of every 3 people who die from opioids, it is from fentanyl or fentanyl-like drugs. Now, Congress has to continue to pass tools to fight this from multiple fronts. First, we need to make the classification of fentanyl analogs as Schedule I drugs permanent. Several of my colleagues and I introduced the Halt Lethal Trafficking of Fentanyl Act last year to do just that. Secondly, we need to educate Americans just how deadly fentanyl is. 2 milligrams is enough to kill someone. I was proud to join Senator Marshall and other doctors in the Congress to record a PSA informing Americans about the risk of fentanyl. Health experts and public officials need to continue such efforts. Thirdly, the border. Last year, the DEA seized 20 million fake pills and 50,000 pounds of fentanyl, enough for 440 million lethal doses. When I went to the border, I saw this big cage of illegal drugs. I said, how much do you think you're getting? We probably think we're getting about 1/3 of it. So if we seize this much, that much more went through. We have to recognize that a policy at the border which has been feckless and ineffective as this administration has had, not just allows people to come here who are illegal immigrants, it allows drugs to come across as well. We've got to control that border. If there's a message I wish the administration to get, use your tools to control. Fourth, we need to combat the drug cartel's ability to finance the production and smuggling of illicit fentanyl into the United States. Selling synthetic opioids laced with fentanyl is a major source of revenue for cartels, gangs, criminal organizations, and for organizations such as Hezbollah. They use a financial process, including one known as trade-based money laundering, to disguise their activities and illegally move this country in and out of the country. It is the use of financial exchanges that look like legitimate trade to serve as cover for illicit flows of money. If we can stop the financing of the drug trade, we can stop the trade of drugs. Finally, we need to look at loopholes in our customs system. For example, cartels will ship Chinese-made fentanyl into our country by mail, claiming the contents of the package is worth less than $800, which is the threshold for paying tariffs. Because it's declared as less than $800, Customs and Border Protection does not inspect the package, and it passes through. It is a glaring loophole in our customs system. I look forward to discussing these solutions and more in today's hearing. Congress failing to address this crisis threatens our national security and risks the safety of the individual who does not know that one pill laced with fentanyl can kill, which means that there will be one more obituary of an 18-year-old child whose life has gone forever. With that, I yield.
Thank you, Senator Cassidy. I will now introduce today's witnesses. Mr. Kemp Chester is the Senior Policy Advisor for Supply Reduction and International Relations at the Office of National Drug Control Policy, or ONDCP. Dr. Miriam Delphine-Retman is the Assistant Secretary for Mental Health and Substance Use and Head of the Substance Abuse and Mental Health Service Administration, known as SAMHSA. Ms. Carol Johnson is the Administrator of the Health Resources and Services Administrator, or HRSA, and Dr. Christopher Jones is Acting Director of the National Center for Injury Prevention and Control at the Centers for Disease Control and Prevention. Thank you to all of you for joining us today for this really urgent discussion on this really urgent crisis. I really do appreciate all of you sharing your time and your expertise. We look forward to your testimony. And Mr. Chester, we will begin with you.
Thank you, Chairwoman Murray, Ranking Member Cassidy, and members of the committee. Thank you for inviting me to testify today on the dynamic illicit drug environment we face in the United States and the administration's approach to addressing it. Drug poisonings and overdoses claimed 108,809 lives in 2021 alone, which represents an American life lost every 5 minutes around the clock. Behind these fatal overdoses are millions of individuals experiencing non-fatal overdoses that are overwhelming our first responders and taxing our healthcare system. And while these fatalities and non-fatal overdoses are the most visible manifestations of our crisis, along with them are tens of millions of Americans suffering from a substance use disorder. And underlying these heartbreaking numbers is the impact on our economic prosperity. The cost of this epidemic is estimated to be $1 trillion a year, and up to 26% of the loss in our labor force participation can be attributed to people suffering from addiction. The administration is approaching this crisis with a keen sense of urgency and with action that is bold, far-reaching, and innovative. The President's National Drug Control Strategy is an evidence-based blueprint designed to save as many lives as possible in the near term, while building our capacity to deal with untreated addiction and the profit-driven trafficking of illicit drugs in the long term. The Director of National Drug Control Policy has further identified 4 immediate priorities that cut across the strategy's goals to achieve these outcomes. First is to have naloxone, the opioid reversal medication, in the hands of everyone who needs it, especially now when 3 out of every 4 overdose deaths involve an opioid like fentanyl. Second is tackling the enduring issue of Americans with a substance use disorder not getting the treatment they need. Fewer than 1 out of 10 people in the United States who need treatment are able to get it. We simply cannot accept that, and we are committed to ensuring universal access to medication for opioid use disorder by 2025. Third, we must disrupt and dismantle the transnational criminal organizations who produce and traffic illicit drugs like fentanyl by commercially disrupting the entire global illicit business of drug production and trafficking, including its illicit financial networks, supply chains, in a holistic and coordinated fashion. And finally, we need to close our existing gaps in data collection and analysis we need to drive and evaluate drug policy decisions, especially for non-fatal overdoses, which are the most accurate predictors of a fatal overdose in the future. Taken together, this represents a new era of drug policy that is precisely what we need now to address an environment of drug trafficking and use that is more dynamic than at any time in history. This is the first time the federal government is embracing high-impact harm reduction to reduce overdoses and deaths. Commercial disruption is a new approach that brings together our efforts in illicit finance, supply chain targeting, and international engagement to target drug traffickers, their operating capital, and their profits. This strategy is the first in which we focused on improving data to deliver life-saving resources to the people who need it, particularly those who interact with the criminal justice system and those who are incarcerated. This is the first time we've emphasized adverse childhood experiences and the social determinants of health as key elements of our prevention efforts. This is the first time we've called for making access to substance use disorder treatment universal, removing outdated barriers to prescribing medications for opioid use disorder, and providing workforce opportunities for people in recovery. In today's environment, dominated by opioids like illicit fentanyl, we must reduce overdose deaths, ensure people can get access to the help they need, and disrupt the flow of illicit drugs across our borders and into our communities. On behalf of Dr. Gupta and the men and women of the Office of National Drug Control Policy, I want to thank this committee and your colleagues in Congress for your leadership on this critical issue. And we look forward to working with you to address this complex national security, law enforcement, and public health challenge with the urgency that it so desperately demands. Thank you, and I look forward to your questions.
Thank you. Dr. Delphin-Rittman.
Good morning, and thank you, Chair Murray, Ranking Member Cassidy, and members of the committee for inviting me to testify during this hearing focused on fentanyl and its impact on overdoses across the nation. I am pleased to be here along with my colleagues from the White House Office of Drug Control Policy, the Health Resources and Services Administration, and the Center for Disease Control and Prevention to discuss SAMHSA's efforts. The overdose crisis continues to be a challenge across the country. Synthetic opioids like illicitly manufactured fentanyl and the use of other substances, particularly stimulants such as cocaine and methamphetamines, have led to significant increases in overdose deaths. The COVID-19 pandemic exacerbated an already tragic situation, with drug overdose deaths reaching a historic high, devastating families and communities. Provisional data from CDC reported that more than 107,000 Americans died due to drug overdose in the 12-month period ending January 2022. Moreover, preliminary findings from SAMHSA's analysis of 2021 data from the drug-related emergency department's visits showed that fentanyl-related emergency department visits rose throughout 2021. That's why addressing addiction and the overdose epidemic is one of the 4 pillars of the unity agenda the President outlined in the State of the Union address. Additionally, last year, Secretary Becerra released a comprehensive HHS overdose prevention strategy, which is designed to increase access to a full range of care and services for individuals who use substances that cause overdoses and their families. The strategy prioritizes 4 key areas: primary prevention, harm reduction, evidence-based treatment, and recovery support. SAMHSA has several efforts underway across this continuum. For example, SAMHSA's First Responders Comprehensive Addiction Recovery Act program trains and equips first responders and other volunteer organizations on how to respond to overdose-related incidents, including how to administer overdose reversal medication naloxone. During the program's recent project period, each state developed a strategic action plan for combating opioid misuse and deaths related to heroin and illicit fentanyl. This year, SAMHSA launched the first ever harm reduction grant program and issued $30 million in grant awards. This opportunity, authorized and funded by the American Rescue Plan Act, is increasing access to a range of community harm reduction services and supports harm reduction service providers as they work to help to prevent overdose deaths and reduce the health risks associated with drug use. We're increasing access to evidence-based treatments to more Americans by allowing practitioners to treat more patients with buprenorphine through the revised buprenorphine practice guidelines. This policy has given over 17,000 more providers the ability to provide this life-saving treatment. SAMHSA's programs like the Substance Use Prevention Treatment Block Grant and the State Opioid Response Grant programs are critical resources for states to fight this epidemic. States can use these funds to purchase fentanyl test strips, which are disposable, single-use tests to detect the presence of fentanyl in a substance. And finally, SAMHSA's Office of Recovery is promoting the involvement of people with lived experience throughout the agency and stakeholder activities, and fostering relationships with internal and external organizations with mental health and addiction recovery field. On behalf of my colleagues at SAMHSA, I want to thank you for your interest and support of our programs and for supporting the nation's behavioral health. I'd be pleased to answer any questions and look forward to our discussion. Thank you.
Thank you. Ms. Johnson.
Chair Murray, Senator Cassidy, and members of the committee, thank you for the opportunity to speak with you today about the work of the Health Resources and Services Administration to address the opioid crisis, which, as this hearing demonstrates, is increasingly a fentanyl crisis. I'm Carol Johnson, Administrator of the Health Resources and Services Administration, the agency in the Department of Health and Human Services that's home to the Federal Office of Rural Health Policy, community health centers, the Ryan White HIV/AIDS program, federal behavioral health workforce training programs, and our federal investments in maternal and child health. Across our work, we're seeing the impact of fentanyl use in the historically underserved communities that we serve, including urban, rural, and tribal communities. And we're committed to improving access to mental health and substance use disorder treatment and growing the behavioral health workforce. I want to focus my remarks today on three key issues related to the crisis that HRSA's work aims to respond to. First, as the chair mentioned, our investments in training and growing the mental health and substance use disorder workforce. This includes psychiatrists and psychiatric nurses, social workers, substance use disorder counselors, psychologists, and peer support specialists with lived experience, who are trained and funded through programs like our Behavioral Health Workforce Training Program that supports direct training and stipends to build the next generation of mental health and substance use disorder providers. The National Health Service Corps, where we offer loan repayment and scholarships to behavioral health students and providers in return for practicing in high-need areas, and our other dedicated substance use disorder workforce programs like the Substance Use Disorder Treatment and Recovery Loan Repayment Program, our Addiction Medicine Fellowship Program, and our Opioid Impacted Family Support Program. We believe that it's critical to expand our investment in this training and deployment of a mental health and substance use disorder workforce that can respond to the prevention, treatment, and recovery needs of individuals struggling with fentanyl use. And that's why the President's budget includes a nearly $400 million investment in growing the number of mental health and substance use disorder providers. It's also why the American Rescue Plan's unprecedented investment in the National Health Service Corps has allowed us to see the largest cohort in the program's 50-year history, including thousands of behavioral health providers. Second, I want to speak to our work to expand access to substance use disorder services in rural communities across the country. HRSA's Rural Communities Opioid Response Program reaches over 1,500 rural communities in 47 states. And we're funding what rural communities tell us they need, including more access to treatment for individuals using fentanyl. In fact, in June, we announced a new $10 million rural investment to tackle synthetic opioid overdoses, including fentanyl and fentanyl-laced drug overdoses, with the goal of creating new treatment access points in rural communities. In June, we also announced a new $15 million rural investment focused on stimulants like methamphetamine, particularly as rural communities have reached out to us for help with their critical needs as they see drugs like meth and cocaine becoming even more dangerous due to contamination with highly potent fentanyl. We also fund other tailored support programs in rural communities, such as grants to reduce the incidence and impact of neonatal abstinence syndrome and our rural centers of excellence on substance use disorder. And we're committed to continuing to help rural communities respond to this crisis. For our third and final point, I want to emphasize HRSA's work to help ensure that there's no wrong door for getting mental health and substance use disorder help. And we want to do that by integrating behavioral health into primary care. And with this committee's leadership, two important steps on that path were included in the Bipartisan Safer Communities Act. The bill gave us new tools and resources to expand mental health training of primary care providers and the funding needed to grow our pediatric mental health access program, to expand our work with pediatricians, as well as reach beyond pediatricians' offices and into schools and emergency departments. We want there to be no wrong door for those seeking mental health and substance use disorder care, which is why we aim to expand the capacity of the primary care workforce to respond to the mental health and substance use disorder needs of the community, including family medicine, pediatrics, maternal care, internal medicine, and others. And we're committed to building on the primary care footprint of the 1,400 community health centers we fund in communities across the country to help reach this goal. We know there's much more work to do and are grateful to the committee for the opportunity to work with you on the next steps. Thank you for the opportunity to discuss HRSA's work, and I look forward to your questions.
Thank you. Dr. Jones.
Chair Murray, Senator Cassidy, and distinguished members of the committee, it's an honor to appear before you today to discuss the Centers for Disease Control and Prevention's efforts to address the overdose crisis. Thank you to the committee for your attention to this important public health challenge. This is a complex issue that requires a coordinated approach, and I'm pleased to be here with my colleagues from SAMHSA, HRSA, and ONDCP. The overdose crisis continues to escalate due to the proliferation of highly potent synthetic opioids like illicit fentanyl and the resurgence of stimulants like methamphetamine. In fact, we've never seen an illicit drug supply that is so potent, unpredictable, or lethal. According to the latest CDC provisional data, of the more than 100,000 overdose deaths in 2021, 75% involved at least one opioid, with 66% specifically involving synthetic opioids and 50% involving stimulants, often in combination with synthetic opioids. These statistics reflect the urgent need for action, and CDC is confronting this crisis through 5 key strategies that complement the work of our sister agencies in HHS and across the federal government. Our first strategy focuses on data, which are foundational to prevention efforts. CDC uses data to stay on the leading edge of overdose trends to ensure that communities have the information they need to respond to the evolving crisis. Through our Overdose Data to Action, or OD2A program, CDC administers 2 key data systems to improve the timeliness and comprehensiveness of both non-fatal and fatal overdose data. The Drug Overdose Surveillance and Epidemiology, or DOSE system, collects near real-time data on non-fatal overdoses in emergency departments. States participating in DOSE have immediate access to their data and can quickly mobilize a community response to surges in overdose. The State Unintentional Drug Overdose Reporting System, or SUDRS, provides detailed contextual information on the circumstances of overdose deaths and the specific substances involved in deaths to inform prevention strategies. To make these data more readily available for decision-making, we recently launched public-facing dashboards for both DOSE and SUDRS. Our second strategy is building state, tribal, local, and territorial capacity. In addition to 47 states and DC, CDC's OD2A program funds 19 cities, counties, and territories, and we fund 26 tribal entities through other cooperative agreements. Under these programs, funding is used to build public health capacity, leverage data to drive action, and support the implementation of evidence-based strategies to reduce overdose. Our third strategy is supporting providers, health systems, payers, and employers. Under this strategy, CDC supports efforts to increase safer prescribing and improve pain care, maximize the use of prescription drug monitoring programs, advance insurer and health system interventions, and link people to care and services across healthcare, community, and criminal justice settings. Our fourth strategy focuses on partnering with public safety and community organizations. For example, the Overdose Response Strategy, a unique collaboration between CDC and ONDCP's HIDA program, helps communities reduce overdose by connecting public health and public safety agencies in all 50 states. CDC also partners with ONDCP on the Drug-Free Communities program to provide grants and supports to hundreds of community coalitions across the country to advance youth substance use prevention. Our fifth strategy is raising public awareness and reducing stigma. To advance this strategy, we recently launched a campaign called Stop Overdose, which focuses on raising awareness about fentanyl, naloxone, polysubstance use, and decreasing stigma. To date, Stop Overdose has reached over 1 billion views. Finally, CDC recognizes the importance of preventing adverse childhood experiences, or ACEs, as a key part of the prevention strategy. ACEs are potentially traumatic events that happen during childhood, and decades of research show ACEs are strongly linked to risk for substance use, addiction, and overdose, as well as risk for mental health challenges and suicide, among other leading causes of death. By focusing on upstream ACEs prevention, we can make substantial progress in preventing substance use and overdose and addressing the behavioral health challenges facing our nation. As a person in long-term recovery, I know firsthand the pain and devastation that addiction can inflict on individuals, families, and communities. But I've also seen the transformative power of recovery, and am grateful to be one of the millions of Americans in recovery that can serve as a beacon of hope to others struggling with substance use. This work is very personal to me, and at CDC, we're committed to advancing a comprehensive, community-driven approach to save lives today, get ahead of the crisis by identifying emerging threats and supporting upstream prevention so the next generation doesn't have to experience this overdose crisis. Thank you for the opportunity to be here. I look forward to your questions.
Thank you very much to all of our witnesses today and for sharing your expertise. We will now have an opening round of questions from senators. Please, again, if you can, keep your remarks or your questioning to 5 minutes. Mr. Chester, let me start with you. As you know, fentanyl has been devastating for all of our communities, including in my home state of Washington. Over 2,000 people died from a drug overdose in Washington state in 2021. That is an increase of nearly 70% over 2019, and half of those deaths involve fentanyl. So those numbers are really heartbreaking. In King County, we saw a record high fentanyl deaths in 2021. Spokane County reported a 186% increase in fentanyl overdose. It's devastating. And because of the transnational criminal networks that traffic fentanyl, it's only becoming more prevalent. The Drug Enforcement Administration recently reported a 264% increase in counterfeit pill seizures in Washington state alone. Law enforcement officials and first responders are working hard to intercept and seize fentanyl before it reaches our communities and respond to the increased use. But the federal government really has to do more. Mr. Chester, share with us what steps ONDCP is taking to coordinate the activities of the federal law enforcement agencies, Department of Justice, DEA, to make sure that our efforts to disrupt fentanyl trafficking is as effective as possible.
Thank you for the question, Senator. And in your question was a great deal of the answer, and that is going after the transnational criminal organizations before the drugs can even get across our borders and into our communities. And it's what we refer to as commercial disruption. What we are dealing with is a global illicit business that has all of the hallmarks of a transnational business organization. They have access to resources, they do product development, they have the ability to move money, products, raw materials across borders with incredible efficiency. They are free riders on the back of the legitimate commercial network that keeps the international economy alive. But it has critical vulnerabilities. And so what we are focused on, and this is across the interagency and across the federal government, is focusing our efforts on those critical vulnerabilities where we can get the greatest amount of effect. And one of them, obviously, as was discussed before, is illicit finance. That's their operating capital and that's their profits. Another one is the precursor chemicals that are used in order to manufacture these drugs. And in many cases now, the technology is to the point where precursor chemicals are no longer regulated, and some of them are so legitimate that they can't be regulated. The third one is going after the commercial shipping that moves these things around the country. And then the fourth thing is the pill presses and the dye molds that are used to make them. And so what we're doing in the Office of National Drug Control Policy is not only working across the federal government, but working bilaterally with key countries like China, like Mexico, and like India in order to be able to disrupt the production of these drugs at their source and to prevent them from getting to our borders and into our communities in the first place. And that is truly an interagency effort, and it is where the bulk of our efforts lie right now.
Okay, thank you. Thank you very much. Let me turn to Dr. Delphin Rittman. For a lot of parents, it's really hard to help their kids navigate teenage years anyway, especially when it comes to drug and alcohols. And fentanyl crisis has made keeping our kids safer a lot harder. I'm a mom, I'm a grandma. I understand exactly how scary this is for parents today. Counterfeit pills with fentanyl are extremely dangerous and extremely easy for teens to find, often accidentally, on social media platforms. The stories from parents and family members and loved ones are heartbreaking. Kids buy what they think are prescription opioids online only to get lethal fentanyl-laced pills instead. And in fact, the problem is so widespread that the Drug Enforcement Administration issued its first public safety alert in 6 years, warning about the dangers of those pills. We've got to protect our communities, especially our kids, from fentanyl. It is vital that we invest in substance use disorder prevention, treatment, and recovery for youth. Talk to us about how this committee can support the efforts, especially in our upcoming reauthorization package.
So, thank you, Chair Murray, for that question. And you're right. I mean, this is such a challenging area. And, I also want to thank you for your bipartisan work to reauthorize our programs. So we do have a specific program, the Strategic Prevention Framework for Prescription Drugs, that is geared towards helping to increase awareness of the dangers of sharing substances, of substance use. It's geared towards raising awareness among youth and families and communities. So this program also does include information and training and technical assistance related to the dangers of buying substances, period, but also through the web, and particularly focuses on youth. So some of the goal is to raise awareness and to change youth behaviors through that awareness raising.
Well, thank you. I am out of time. Dr. Jones, I wanted to ask you what efforts has CDC is doing and how we can support that. If you can give that to me in writing, or if I can get her back around to a second round of questions, I will ask you that question. Senator Cassidy.
Thank you, Madam Chair. Mr. Chester, I'm getting feedback. Do you mind turning that off? Thank you. Still getting feedback. Still getting feedback. Oh, well. It's irritating me, so it's probably... Let's try that. Mr. Chester, I'm struck that I can speak about chemical providers in Wuhan sending chemicals here that are precursors for fentanyl that are used by Mexican cartels or else shipped directly. You can acknowledge it in your testimony. Now, we think of China as an area where they have surveillance cameras on every corner, in which at any point someone may be arbitrarily imprisoned. I could go on, but we know what the go on would be. So how much collaboration are we getting from the Chinese in terms of this? Because someone has suggested this is a form of bioterrorism.
Yes, Senator. No, thank you very much for the question. I could tell you that we engage regularly with the People's Republic of China on this specific issue. And although, as you know, we have a very complicated relationship with China, this is an area where U.S. and PRC interests align, and we have made progress in the past. The most notable was our work up until May of 2019.
Let me stop you, though. I'm sorry.
Yes, sir.
But if we know who those chemical manufacturers are, the Chinese know who they are. So, yes, there may be collaboration.
Right.
But there's a fundamental breakdown here, right?
Yes, sir. And the first thing is ensuring we have open lines of communication so the information that we have, that we understand about seizures in the Western Hemisphere can be sent to the Chinese so that they can take action on it. The second part of that is, and something that we've clearly communicated to the Chinese, and you mentioned it in your opening statement. I think you brought up a very good point when you talk about the mislabeling. We have asked the Chinese government to do three very simple things. The first one is agree with us on the list of unregulated chemicals that are used to create precursor chemicals that bear increased scrutiny. That's the first thing. The second thing is to properly label their chemical and equipment shipments in accordance with the World Trade Organization. And the third one is that they know their customer and put know your customer procedures into place. Those are the things we should expect of any responsible country. We've asked other countries to do this as well, and we look forward to working with the Chinese for them to implement these procedures to reduce the flow of these precursor chemicals into the Western Hemisphere.
Now, we've been raising this issue with the Chinese for several years now. So I guess what I'm after, which I'm not sure I'm getting, is a level of collaboration, true collaboration, as opposed to, hey, we're with you, as opposed to, no, we're knocking on doors and we're shutting down people and we're throwing them in jail.
Right. I would tell you that in the relationship that we have with Chinese, with the PRC, has given us uneven progress. I won't disagree with you on that. I think that there are areas where the Chinese government has taken quick and decisive action at a request of the United States, and it's had good results. I think there are other times that we have differences with the government of China procedurally on certain things that we ask them to do, and we have to ensure that we continue to communicate with them and press to them how incredibly important this is, not just the United States, but to the rest of the world. And other countries, and Secretary Blinken brought this up in his speech about China, other countries should expect two great countries like the United States and the PRC to work together on this global issue, and they understand that.
Now, looking at Mexico, now you have a sense that Mexico is always teetering on whether or not it's in control or not, and several states apparently are not in control of the central government. But to what degree has the Mexican government collaborated with us if these cartels are bringing these these drugs from China to then bring across our border? To what degree are we getting collaboration there?
We have a good and long-standing relationship with the government of Mexico, which was solidified in the bicentennial framework for security that was signed just a few months ago that replaces the previous Merida initiative. That is a little bit more holistic and takes in more of the contributing factors within Mexico, not just the security side of the house. And we have on the ground, we have a large embassy down there. We have deep law enforcement relationships with the government of Mexico, and we have had cooperation in the past. And most recently, obviously, the apprehension of Rafael Caro Quintero is a good example of cooperation with the government of Mexico that actually bears fruit.
Now, but I had a sense that recently there was some increased liability for some of our agents who might be down there should something go wrong. And I also had a sense that President, or I'll just call him AMLO, the President of Mexico, has less affection for the U.S. than perhaps some of his predecessors. Any comment on that?
What you're referring to is the national security law that was put in place in January of last year that created a bunch of increased procedures for collaboration between Mexican and U.S. law enforcement agencies. I think on the ground that has been worked out in practical terms that it's not had a devastating effect on law enforcement cooperation in Mexico. That's not uniform across all agencies, but I think in general terms, the national security law isn't a barrier from us working with Mexico. But I think it is clear that President Lopez Obrador sees really two things. The first one is he wants to go after the root causes of criminality. And the second thing is he continually looks at the U.S.-Mexico relationship in terms of Mexico's interests as much as United States interests. And so it has caused a recasting of our relationship with Mexico. But we have made some progress on this particular problem when working with the government of Mexico.
I yield.
Thank you. Senator Murphy.
Thank you very much, Madam Chair. Thanks for this hearing. You're all doing super important work. We appreciate the testimony. Dr. Delphin Rittman, I wanted to talk to you about the genesis of the opioid crisis, which, of course, at first is rooted in America's penchant to prescribe opioids and addictive pain medication at a rate that is unparalleled in the rest of the world. We've made a lot of progress when it comes to the overall number of opioids that are prescribed in this country. And there is a direct line between individuals who become addicted to these pain medications and then those that end up seeking illicit drugs in black markets that often end up having fentanyl attached to them. So we've seen this drop in the number of opioids that have been prescribed, and we sort of pat ourselves on the back. And yet, when you look at our numbers, even with this drop compared to the rest of the world, we are still a crazy outlier, right? We are still 5% of the world's population and somewhere between 70 and 80% of the world's opioid prescriptions, even with a 40% drop in the overall number of prescriptions that are being made. So just talk for a second about, as we're talking about the fentanyl crisis here, the work that we still have to do to alter prescribing patterns as a means to stop people from getting on this pathway to fentanyl.
Yeah, thank you for that question, Senator. And the prescribing patterns and, ultimately ensuring that people have access to evidence-based services and supports is so critical. We've seen that over time, and we know that the evidence-based practices and treatments such as medication-assisted treatment, whether it be buprenorphine or methadone, can help people who are struggling with opioid-related substance challenges. In terms of prescribing patterns, one thing that we're working on is to increase that access for individuals that may be struggling is to allow individuals, prescribers that is, prescribers to treat up to 30 individuals with buprenorphine. And so we've revised the buprenorphine practice guidelines such that those individuals can treat individuals struggling with opioid addiction with buprenorphine.
But I guess what I'm talking about, right, pain management. I'm talking about the fact that we still are prescribing far more pain medication, addictive pain medication, than the rest of the world, and that we've got to, from your perspective, right, you've got to focus on trying to find alternative ways to manage pain so that people never get in the position of being addicted to pain medication that then becomes an addiction to heroin, fentanyl, et cetera.
Yeah. Yes, and we do have grants actually that do that type of training. So, for example, our state opioid response grant does train providers on alternatives to pain management, such that prescription medications aren't the first course, and so other strategies to manage pain, and that can help to alter and change some of the prescribing practices that we are seeing.
Mr. Chester, I wanted to talk to you a little bit about how fentanyl and other illicit substances come into the United States through the southern border. It is still true, correct, that the lion's share, the vast majority, not all, but almost all, of the product coming into the United States comes through our ports of entry. And we have made, through the Appropriations Committee, I chair the subcommittee that writes the budget for DHS, some significant investments in technology at those ports of entry. But there sometimes is an impression here that a lot of this product is being, moved across in the dead of the night through the desert. But the reality is we still don't catch as much as we should that is walking straight through public ports of entry. And there's additional investments that we can make to try to catch more of it and ultimately deter more of that activity.
Yes, Senator, no, you're correct. So the preponderance of the drugs do come through the existing ports of entry. The technology that they have available is very impressive, and the men and women of Customs and Border Protection, those are our most experienced folks on the ground. And it is the most efficient way to be able to move them across and then have access on the other side to an available network to get them quickly across the country. So they do come through most of the ports of entry. But there is obviously more that we can do. And so, the President's budget asked for $300 million in enhancements for Customs and Border Protection for that very reason, that this is an evolving threat. But there are other places, obviously, through the mail system, through maritime conveyances, that these drugs get into the country as well.
I just make that point, Madam Chair, because a lot of our colleagues think that by putting up this wall on the border, you're going to stop fentanyl from coming into the country. The reality is fentanyl is coming in through the ports. And so we can make investments, but the idea that it's the unwalled portions of the border where the fentanyl is pouring in is just not what the facts bear out. Thank you, Madam Chair.
Thank you. Senator Marshall.
Thank you, Madam Chair. Dr. Jones, do you consider the fentanyl crisis to be a public health emergency?
Yes, and there is currently a public health emergency declared for the opioid crisis.
Okay, thank you. Like every state, my home state of Kansas is now a border state. That's right. As you can see from this map behind me, Kansas is literally at the crossroads of fentanyl trafficking, with 3 major arteries coming out of Mexico, piercing the heart of our great state, and all 3 bisecting the nation's busiest east-west byway. We are now at ground zero. In fact, just recently, officers in Kansas City, Kansas, seized nearly 15,000 fake pills laced with fentanyl during a 2-day bust. Fentanyl is now killing a Kansan almost every day. It's killing over 250 Americans every day. Sadly, fentanyl is now the #1 killer of young adults. Poisoning deaths, and I mention and I stress, these are poisoning deaths from synthetic opioids, particularly fentanyl, have increased by more than 600%. So where does it come from and why is it so cheap? As we all know, the fentanyl precursors are made in China, and yes, you could call this China's revenge on the West for opium war. In Mexico, Chinese chemists and their cartels convert these precursors into fentanyl, and they lace fake pills like Adderall or Xanax or Percocet, or they mix them with illicit drugs like meth and cocaine, or simply they sell it in various pure forms. Unfortunately, this is one supply chain from China that's not broken. It goes without saying, with an open, porous southern border, the supply is abundant, driving the street price down. For where oxycodone tablets maybe cost $60, you can pay $2 to $6 for a fentanyl tablet. One final point I want to go back to, returning to this fake pills concept. Dying from fentanyl is poisoning. It's not an overdose. That's poisoning. If a non-suspecting student takes a fake Adderall pill they purchased online or wherever they purchased and dies, that's poisoning, and the criminals should be tried for murder. At least that's how I see it. Mr. Chester, would securing borders and decreasing smuggling impact the fentanyl crisis?
Yes, Senator. I mean, as I said in response to Senator Murphy as well, the men and women that we have at our southern border are the finest of the
We understand, but you agree it would have a significant impact. Dr. Jones, same question. Would securing our borders and decreasing the smuggling, the easy access to fentanyl, impact the crisis?
I would reiterate Mr. Chester's points about the efforts in the National Drug Control Strategy to address.
But they're not
drugs that are
working.
coming
You can reiterate the points, but obviously with a 600% increase in deaths, whatever we're trying to do, reiterating the points, forming committees, talking to people, something's not working. Dr. Jones, do you believe we should apply Title IV to drug smuggling across the southern border?
Well, Title 42 is rooted in protecting public health from communicable diseases. So while there is a declared 319 public health emergency for the opioid crisis, it falls outside of the scope of Title 42.
Okay. Mr. Chester, you stated that first, the most important action we can do right now is to give more naloxone out. You know, as a physician, that's like telling me to give people with brain tumors Tylenol, to say that that's the most important thing. Do you really feel that giving out naloxone would have a bigger impact than securing our borders?
Senator, by most important thing, what I meant was most important thing in saving lives now, because it can reduce an opioid overdose. But that is not exclusive of all the work that's being done at the southern border and with other countries and with the Postal Inspection Service and all of the other means that we do to keep the drugs out of our communities. The naloxone is designed to reduce an overdose death and save a life immediately.
You know, what we're doing now is we're putting a finger in the dike, and the entire dike is giving away. If we don't secure our borders, this epidemic is only going to get worse. Mr. Chester, you also stated that the U.S. routinely engages with the People's Republic of China to address shipments, and you go on to say that PRC's actions in that regard have a direct and positive impact. How can you objectively, quantitatively substantiate your statement when we're seeing a 600% increase in deaths? I know you're talking to them. I know there's collaboration, but what's your objective evidence that says that China is doing anything to slow this machine down?
The best example I can give you is the work that we did with China prior to May of 2019, when China class scheduled all fentanyl-related substances, and as a result, the direct shipment of fentanyl and fentanyl-related substances from China to the United States went down to almost zero. Now,
And that was in 2019?
that was in 2019, yes, sir. Now, the traffickers moved from producing finished fentanyl into precursor chemicals, which they supplied to Mexican suppliers, and that went up. But that speaks to the dynamic and interactive nature of very determined, profit-driven
So
drug
quantitatively, what have you done that can show me that we've impacted that? What is there any objective evidence that we've impacted China's supplying this? I mean, they're sending it to us like we send wheat to them.
The number of seizures of precursor chemicals and pre-precursor chemicals in the Western Hemisphere has been consistently high, and in many of those cases, that was due to cooperation with Chinese officials, or subsequent to the seizure, the information was sent to the Chinese officials so that they could take action and hold the individuals responsible.
Well, thank you, Madam Chair. I yield back. But the point is, the seizures are going up because objectively, China is not stopping the supply of these precursors. Thank you. I yield back.
Senator Hassan.
Thank you, Madam Chair, and thank you to all of our witnesses for being here today. I want to start with a question to you, Mr. Chester. Deaths from fentanyl among teenagers more than tripled between 2019 and 2021. As Chair Murray mentioned, many of these teens were not seeking fentanyl. They purchased what they thought was Percocet, oxycodone, or Adderall, only to take a fatal dose of fentanyl. And the stories are truly heartbreaking. How are young people getting exposed to these fentanyl-laced drugs?
Thank you for the question, Senator. And I think the distinction was made between poisonings and overdose deaths, and I think it's an important one because you bring it up in your question. Unfortunately, they're being exposed to these drugs in a greater variety of means than they ever were before, and in many cases, and Dr. Gupta has said this several times, getting access to these drugs is as simple as in the palm of your hand through a social media app. And so when we're dealing with global drug traffickers who want to reduce their risk and reduce their overhead and increase their customer base and increase their profits, it is in their interest to make it available through a variety of means. And so the first thing is to have access to them through social media apps, through the dark web, sometimes through the clear web, sometimes through their own personal interactions. The second thing is how those drugs move across our borders and into the United States. And in some cases, it's the southwest border, but in some cases, it's through our mail-in express consignment. And the work we've done with the Postal Inspection Service, where the number of seizures in the mail has increased, I think has been admirable in being able to disrupt that vector coming into the country.
Thank you. Another question for you. Last year's National Defense Authorization Act included a bipartisan bill that Senator Toomey and I authored, the Blocking Deadly Fentanyl Imports Act. This law requires the government to publicly identify countries that are major producers or traffickers of illicit fentanyl and cut off foreign aid to those countries if they fail to increase efforts to fight drug trafficking. Mr. Chester, what steps has the administration taken to evaluate whether we should cut off foreign aid to countries due to the production or trafficking of fentanyl and fentanyl analogs within their borders?
Thank you for the question. I'm sure you understand I can't take a position on pending legislation. What I can tell you is that the current process that we have, that we apply under the majors list process for plant-based drug-producing countries, has been effective over the years, and we welcome any tool that gives us the ability to be able to deal with this.
Thank you. I appreciate that. How's our audio here? Okay, we're
I
good.
can hear you. I'm not sure we can hear the witnesses.
Okay.
Is it off?
I think we're all right now. I want to turn to Ms. Johnson with another question, and I appreciate Mr. Chester's response to the last one. Ms. Johnson, according to the Department of Health and Human Services, the country must add more than 100,000 general psychiatrists and 43,000 addiction psychiatrists to meet the current need. This shortage impacts states like New Hampshire, where patients may have to drive hours to find treatment for a substance use disorder. As part of funding I helped advocate for, the Department of Health and Human Services awarded a $1.4 million grant to Dartmouth-Hitchcock in January to train behavioral health clinicians, paraprofessionals, and other residents of rural New Hampshire communities to address the substance use disorder needs of residents. Ms. Johnson, how will these grant programs help build the behavioral health workforce over the long term? How will they help rural areas in particular?
Thank you, Senator, and thank you for your leadership in supporting and developing these critical programs that are really part of what it's going to take for us to confront this crisis, for us to be able to build critical programs that my colleagues across the table have identified. We need a workforce to be able to deliver on that. And it's the types of programs that you've helped create that give us the tools to be able to recruit people into the field, to get them the training that they need, and then to deploy them into the communities where they're needed most. So we're looking forward to the work that will happen at Dartmouth under the grant program.
Well, thank you for that. Quickly, I have a question for Dr. Delphin-Rittman. While we know that medication-assisted treatment like buprenorphine is the gold standard for opioid use disorders, access to treatment is limited by the requirement that providers obtain a special DEA waiver known as the X waiver in order to prescribe buprenorphine. About 40% of counties across the United States in 2018 lacked even a single waivered practitioner who was able to provide this treatment. Dr. Delphin-Rittman, if the X waiver continues, how will the lack of treatment providers offering medication-assisted treatment impact fentanyl overdose rates?
Yeah, thank you for that question, Senator, and for all of your work in this critical area. We know that it is just vital that people have access to medication-assisted treatment when they're struggling with opioid use disorder. Data shows that it can help people move into long-term recovery along with other services and supports. In terms of increasing the number of providers, we have removed some of the barriers, and we're in full support of removing barriers to such that additional providers can prescribe buprenorphine, and that's why we changed some of the training requirements along with the buprenorphine guidelines, as you know. And so that did bring an additional 17,000 prescribers into the field, since we put that in place.
Well, that's important, but I think we have more to do. So I've introduced the Bipartisan Mainstreaming Addiction Treatment Act, which would eliminate the X waiver and expand access to treatments that we know will save lives. Thank you so much, Madam Chair.
Thank you. As senators know, a vote has been called. I'm going to call on Senator Moran and Senator Lujan. I will go vote and come back. Senator Casey will hold the gavel while I'm gone.
Chairwoman, thank you. Thank you very much for your presence today. Let me start with Administrator Johnson. In your testimony, you mentioned that HRSA is working on better connecting substance abuse disorder treatment with access to mental health care. I come from a state, but I also come from a nation in which access to mental health care is limited for a number of reasons, but particularly the rural parts of our state, the inability to attract and retain healthcare professionals is a huge issue. I see this in my Veterans Affairs Committee, where we're trying to take steps necessary to prevent veteran suicide. The services, if they exist, are distance away. Senator Smith and I recently introduced a bill authorizing a grant program under HRSA to help primary care practices integrate behavioral health care services into their offices, designed to take those circumstances in which you do have a hometown physician, a family practice doctor, and bring mental health care services to that practice. Do you think better integrating behavioral health services into primary care settings for adults and children makes sense? And would that help address the substance abuse crisis that our country is facing?
Thank you, Senator. Thank you so much for your leadership on this issue. I think integrating behavioral health, mental health, and substance use disorder services in primary care is essential for us to confront this crisis. We are not going to be able to solve this problem unless people can get the care and services they need, and that means we have to deploy all available assets to the problem, and that means there needs to be no wrong door for getting in to get mental health and substance use disorder services. And that's why we're really focused on trying to leverage the programs at HRSA and are grateful for the support of this committee to identify ways that we can continue to help the primary care workforce understand and treat and identify mental health and substance use disorders.
Thank you. I intend to use your endorsement in our efforts to get the legislation passed. Dr. Delphin Rittman, in addition to serving on this committee, I'm also the lead Republican on the Appropriations Subcommittee that funds the Department of Justice. In your testimony, you touched on the First Responders Comprehensive Addiction and Recovery Act grant program, which helps to train and equip first responders to respond to overdose-related incidents. This grant program, as you noted, includes a rural set-aside. For many rural departments, the loss of man or woman power while an officer or deputy is off training is almost as prohibitive as the lack of funding. What is your department doing to make training and other resources more accessible, such as through online training courses to small and understaffed departments?
Thank you for that question, Senator. You're right. I mean, it's so important to be able to have multiple modalities to be able to offer training. And so we do have a number of training and technical assistance centers. So we have an addiction training and technical assistance center, as well as the provider clinical support system that provides a range of technical assistance training and education for prescribers, as well as other behavioral health providers in the field. And those include both in-person as well as remotely through webinars and online strategies and means as well.
I might suggest to you that, at least in our state, we have a number of law enforcement training centers across the state geographically. Mm-hmm. You may want to integrate your program or share the opportunity for training in those settings and utilize the services that generally law enforcement community has already created for ongoing training for members of law enforcement. I also appreciate your attention to ensuring that rural communities have the resources needed to fight fentanyl and substance abuse. There are two issues. These two issues are often associated with urban areas. I can assure, as you know, it is not a urban-suburban issue. It's not solely that. Rural America is battling the epidemic, and we are doing so with, as I indicated earlier, a more strained healthcare delivery system and limited workforce. One particular program you talk about in your testimony that Kansas is utilizing well is the Certified Community Behavioral Health Clinic programs. In 2021, Kansas became the first state to establish the model at the state level, and by 2024, we have 26 state-certified CCBHCs. Would you speak further to the role of localized care like these community mental health centers have in fighting substance abuse that we're talking about today?
Yes, absolutely. And I want to commend Kansas for having that number of CCBHCs. It is a wonderful model. It provides both mental health, substance use services, as well as coordination and connection and linkage to primary care services as well. It's a model that also provides wraparound prevention, treatment, and recovery services and supports. And so it's critical in terms of being able to connect people that are struggling with opioid use disorders, as well as other substance use disorders, to services and supports, to include recovery services and supports as well.
Thank you both for responding to my questions.
Senator Lujan.
Let's see, there we go. Thank you very much, Mr. Chairman, Madam Chair, for this important hearing. I do want to start by echoing something from my colleague from Connecticut and bringing attention to our ports of entry. Somehow this keeps getting politicized. If, in fact, the United States wants to be serious about stopping the flow of illicit substances into the United States, we must remember there's a southern border and a northern border, and there's two water borders, and then you go down and you remember the Gulf of Mexico with our water ports. Don't forget about our airports. The screening, or lack thereof, that is done at our ports should alarm all of us. 5 or 6% just improved to 10% with passenger screening into the southern border is embarrassing. The United States must adopt 100% screening into the United States with commercial goods and with passenger traffic at all of our ports of entry. Only then will we start to understand how these cartels and other entities are throwing product at the problem. So I hope that we can at least come together there and work together to get something done. By the way, one of the last pieces of legislation that was signed by President Trump was a bipartisan initiative challenging the Department of Homeland Security to tell Congress how to get to 100% screening of our ports. Let's find a way to work together. Second, Mr. Chester, I appreciate the attention to the illicit financial markets. The United States should be embarrassed by the lack thereof process that we have with prosecuting against illicit financial markets. And it's not just Democrat or Republican administrations. It is both. When major financial institutions in the United States are found to be laundering money for cartels, and the outcome is no one goes to jail, someone gets a fine, well, that's just the new cost of doing business. If someone can make that much money and only get fined, it's going to continue. If there's one thing that all these bad people have in common and what's happening here, it's that they're making money. And until you stop the flow of that money, you're not going to stop any of this. And so I'm hopeful that these are some areas, I know we're not in the Committee of Jurisdiction, but some areas that we can find some common ground to go after these entities that are not politicized. Now, the questions that I have, I want to echo a statement that was made earlier, pushing on buprenorphine or improving screening at ports of entry in America. Dr. Delphine Rittman, does the United States need to adopt both access to treatments as well as trying to stop these movements of these illicit substances from around the world into the United States?
Thank you for that question, Senator. And, I can certainly speak to the work of SAMHSA, and I know Mr. Chester has comments in terms of the movement. It does seem that we're taking a multi-level approach, and so certainly there is quite a bit of work underway to increase access to medication-assisted treatment, as well as other vital prevention and recovery services and supports as well. And it does sound like there is quite a bit of work in terms of work at the border as well. But in terms of SAMHSA's, the programs and initiatives that we have in place, both through the SOAR, so State Opioid Response Grant, as well as the Substance Abuse Treatment Block Grant, there are a range of services and supports available across the country to help individuals that are struggling with opioids, to include the dissemination of fentanyl test strips, which allow for testing of substances and allow for the testing of the presence of fentanyl.
Dr. Delphine Rittman, would access to fentanyl testing strips save more lives?
So what we are seeing is that fentanyl test strips do allow for the identification of fentanyl and substances that is helpful for individuals that are not interested in, that don't want to take fentanyl. Often what we find is that harm reduction programs also disseminate information about how to access services. Often people are connected with a recovery coach or recovery programming. So the harm reduction offers an opportunity to sort of disseminate the fentanyl test strips, but also to disseminate information about how to navigate and access services and supports as well.
I believe access to those strips will save lives. It alarms me that in some states, those strips are treated as illegal use or treated in a way where people can't use them. I hope that the one thing we can do is come together to ensure that access to strips, things of that nature, is something that can be accessible across the United States. I do have other questions for the record that I will submit. The one point that I wanted to raise, though, is according to the CDC, only about 1 in every 10 American Indian, Alaska Native, and Hispanic people with substance use disorder reported receiving treatment. So the number is about 70% of the 2 million folks across the country that are not getting any treatment, predominantly in rural and Native American communities, and in Hispanic communities, Black communities, other communities of color as well. I appreciate that there's more attention being brought to these, but again, what's been happening? The data shows where this is occurring, and there's still no response. Madam Chair, Mr. Chairman, I'm certainly hopeful that as we have this conversation and we are moving to move legislation to encourage more and demand more access to MATs, but that we understand where the data is based on the number of folks that we're losing, while we also stop these illicit financial markets and we improve dramatically and require 100% screening at our borders to begin to make the drastic steps necessary to be able to get our hands around this. Thank you. I yield back.
Senator Collins.
Thank you, Mr. Chairman. Members of the panel, I say this with great respect for each of you. I know that you care deeply and that the policy and programs that you are implementing are well-intentioned. But I think we have to face the very unpleasant truth that what we're doing is not working. The data overwhelmingly demonstrate that. Whether you look at national data or data from the state of Maine. Maine's leading drug overdose drug death researcher, Dr. Marcy Sorg from the University of Maine, recently called Maine's overdose epidemic, quote, the worst it's ever been, end quote. Tragically, we lost a record high 627 Mainers in 2021, and the data from the first part of this year shows a 9% increase over a comparable period of last year. The number of total overdoses in Maine exceeded 9,500 last year. Fentanyl was involved in 77% of deadly overdoses in Maine. That's a dramatic increase. So I want to talk to you about two issues. One is enforcement and interdiction, and the second is prevention and education. In 2021, the Maine Drug Enforcement Agency seized more than 10,000 grams of fentanyl. That's a 67% increase, but they tell me they cannot possibly keep up. They are overwhelmed, and that Maine's overdose crisis is primarily driven by the increased supply of illicit fentanyl originating in China and smuggled through Mexico into our country. I've been to the border with Mexico. I've seen the cartels who are smuggling people across the border. I've talked with the Border Patrol officers out on their midnight shift, And they've expressed such frustration that they have had to divert their resources to handling the tremendous influx of people crossing the border rather than focusing on illicit drug interdiction. So like my colleagues, I cannot help but conclude that our inability to secure the southern border has an adverse impact and contributes directly to our inability to stop the flow of drugs into this country. I've also talked to the Coast Guard and their efforts and how frustrated they feel. So my first question, Mr. Chester, is do you agree that the unprecedented surge of people illegally entering the United States has diverted limited government resources away from drug interdiction?
Thank you for your question, Senator. And I know Marcy Sorgan. I've worked with her for the past several years, and she's an incredible professional.
She is.
And understands this issue better than just about anybody. So
Thank you.
I appreciate that. There is no doubt that there are a number of challenges at the southwest border of the United States. But what I would ask that we all bear in mind is a couple of things. The first one is these are very determined drug traffickers who are going to find any means to get these drugs into our country, whether it's the southwest border, whether it's the mail, express consignment, maritime, or air conveyances. I think that's the first thing. I think the second thing is our focus that we have not only in commercial disruption, but going after the illicit finance, not only the profits that are the motivation for doing this, but the operating capital that allows it to happen is an overarching way to be able to deal with this very frustrating problem. And the last thing I would tell you, ma'am, is this is a very dynamic problem and a very dynamic situation. And when you say that what we're doing is not working, it would be easy to say, well, what we have done is not working. What we have to do is very quickly identify when we have new vulnerabilities, when the traffickers have changed the ways that they do business, and close those gaps and vulnerabilities as quickly as we possibly can. And that's what we're in the process of doing right now.
Thank you. I'm going to submit my next question for the record because my time has expired, but Dr. Delphin Rittman, it is for you. I just want to tell you about Hannah Flaherty, a 14-year-old girl from Portland, a straight-A student with no history of drug abuse who died from a suspected fentanyl poisoning last month. And my question for you is going to be, for the record, given the time, what more can we do to reach young people? And I'm not talking just about high school. I'm talking about middle school students, to educate them about the dangers of drug abuse so that they don't think a pill is harmless. It's injecting yourself, which is dangerous, which I think is a common misperception. And I would like to follow up and talk with you about that because I remember very well when I was growing up in Caribou in northern Maine that we had a recovered heroin addict come in and talk to us, and it was so powerful. It was incredibly powerful. So I'm wondering what more we can do to educate students at a young age about the dangers. And I know I'm out of time, but thank you.
Thank you, Senator Collins. It's a critical question, and I think we all would look forward to your answering that in response. Senator Baldwin.
Thank you, Madam Chair. I'm listening to my colleagues as well as the responses, and there's sort of a pattern that I have observed over time. When we were talking in this committee about the opioid epidemic just several years ago, it was much more, the conversation was much more focused on prescribers and overprescribing and 30-day supply after dental surgery rather than something that would be much more appropriate to avoid substance use abuse. Now we're talking a lot about accidental overdose and getting folks who have gotten fentanyl-laced pills, et cetera. I'm like my colleagues, I want to share the stories of several Wisconsin families that I've gotten to know this year because they've gone through this crisis themselves. Cade Reddington was a graduate of Wanakee Community High School, a student at UW Milwaukee, and a kid who was full of life and energy and excitement. On November 4th of last year, Cade died in his dorm room after taking what he thought was a Percocet pill. That pill contained fentanyl. Combating fentanyl is a critical task for this committee and this entire administration. But I'm concerned we're not doing enough to warn our nation's young people about the dangers of counterfeit pills. So Dr. Jones, I wanted to just draw your attention to the work that, and I'm sure you know about it, the work that the DEA has been doing to spread the word that, quote, one pill can kill. This message, in my mind, has not yet been shared widely enough. And so I wonder how the CDC is working with the DEA to elevate this particular message and make sure that this information is being shared with young people.
Great, thanks so much for the question. And we worked closely with DEA before that campaign was launched because we have experienced over the last several years multiple campaigns that we've done at CDC around prescription opioids, transitioning to recovery, and now the illicit fentanyl market. So we had learned lessons along the way about how to communicate and wanted to make sure that we could assist DEA in their messages. So we worked with them prior to the launch, and we certainly worked across agencies here with DEA to help disseminate those messages. I think that campaign is an important one because it is very catchy. One pill can kill, that makes sense. And that's something that is not lost on people. And it does reflect the toxicity of the illicit drug market. As many senators here have mentioned today, the issue of poisoning versus overdose. And I recently participated in a DEA event that brought families together who have lost individuals through those exact scenarios, taking counterfeit pills that they thought was Xanax or Percocet and was actually pressed fentanyl. But I think I'll highlight two things at CDC that I think complement the work of DEA and how we can continue to spread these messages. So the first is our Stop Overdose campaign, which I mentioned in my opening statement, which focuses specifically on fentanyl and the toxicity of the illicit drug market, the availability of naloxone, polysubstance use, which is also contributing to overdose, as well as unintentional exposure, people thinking they're using something else and they're actually getting fentanyl, and then decreasing stigma, which we know is a barrier for people to seek help. That campaign was formally tested among young adults, 18 to 34-year-olds. And so that is something that is freely available. People can take what we've done and use it and apply it in their communities. So that is, I think, a new asset that is available to help spread the message about the toxicity of the drug market. And the last thing I'll say is that there is a real opportunity to focus on upstream primary prevention. We need to get messages out about the toxicity of the drug market, but fundamentally, as a long-run strategy to addressing this issue, we need to help instill resilience, life skills, problem-solving, conflict resolution, focus on root causes like adverse childhood experiences that really set the trajectory for someone to have risk for substance use. We know that people with ACEs initiate substance use earlier, which increases your risk of having a substance use disorder. So there are really powerful opportunities for public health prevention in that space.
Thank you, Dr. Jones. And I didn't want to cut you off because this is very responsive to my question. I will do as Senator Collins did and submit some questions for the record, but I did want to indicate that both Cade, who I just told you about, and Nicholas Barrett Graves of Beloit have passed away of fentanyl poisoning. Nicholas of Beloit, Wisconsin, could have been saved by naloxone, as could have Cade. And that's why I've been pressing manufacturers to make their products available over the counter and working on legislation to reauthorize the opioid overdose reversal medication access and education grant programs. So for Dr. Delphin-Rittman, again for the record, I'll be inquiring what SAMHSA needs to make sure that naloxone is more readily available to first responders and in key locations such as school dormitories and community centers. And that'll be submitted for the record.
Thank you. Senator Braun.
Thank you, Madam Chair. Question is going to be for Mr. Chester. Want to cite a few things that I think most Americans would be appalled at what's happening. Since 2021, January, 3.2 million migrants have crossed the border illegally. We've intercepted 1.2 million pounds of illegal drugs, over 16,000 pounds of fentanyl. That's approximately 3.7 billion lethal doses coming into the country. Could kill the population 10 times over. Also, we've got 100,000 per year overdose deaths nationally and 2,000 opioid overdose deaths every year in my state of Indiana. I don't know that we need to dispute the facts. I think mostly what I'm interested in, looked at your background. It's impressive in that it's kind of been your job to figure out how to disrupt the supply chain. Of course, now the main manufacturer is China. The main distributor is Mexico. When I was down there in March, I think, of 2021, illegal crossings were 40, 50,000, going up to 60 or 70. Now they exceed 200,000. We all remember the vivid interception recently of I don't know how many pounds of fentanyl. Are you confident that what we're doing is aggravating the problem, just encouraging more proportionally from what it was pre-Biden administration, and are we making any headway?
Thank you very much. That's a very comprehensive question, and I want to hit all of it. The first thing is, I would ask that we all bear in mind that there has absolutely been an increase in the number of drugs seized at our southwest border, and those are drugs that are not in our communities, and that's money that will not go to drug traffickers for their benefits. And I think that's the first thing. I think the second thing is, and I think I've mentioned this before, what you described very accurately is the results of a global business enterprise that is driven by profits and is focused on finding vulnerabilities in order to expand their customer base and make as much money as they can with a decreased amount of risk. And synthetic drugs like fentanyl and synthetic opioids can be produced at much lower overhead and sold for much more money. And so that's the second thing. And then the third thing is that this is not confined, the problem doesn't begin or end at the southwest border, but rather it is deep in a country where those drugs are produced. It is the conveyances that move them and their raw materials around the world, and they're shipped through multiple means into the United States and into our communities. And so what we cannot do is take individual pieces of that complex and focus our efforts on it and ignore the others. We have to look at it in its totality. We have to determine when there are changes in that environment and focus our efforts against those changes for the ultimate goal, and you use the exact right word, I think, in disrupting over time their ability to be able to move these drugs into our country. And so snapshots of time, I absolutely understand that they give certain numbers and certain indicators. What I can tell you is we're approaching this in a holistic fashion, which is what it deserves, because that is the complex of issues that we're dealing with under this particular drug trafficking environment.
Let me follow up with this, because that sounds like a good approach in terms of how you're analyzing it, but we had 40 to 60,000 illegal crossings about a year and a quarter ago. Now it's up to over 200,000. And what they told us then was that the wall, which I don't think ever was talked about being from sea to shining sea, where it was their most important tool along with the stay in Mexico policy. So how do you explain why it's gone from 40 to 60,000 illegal crossings to what could be approaching 300,000, and how we could be doing a better job at intercepting all the illicit material that comes along with the illegal crossings.
Yes, Senator, thank you. And please understand, I'm gonna limit my comments and my answers to the issue of illicit drug trafficking. But what I can tell you is that is precisely why in the President's FY23 budget, we've asked for $300 million to enhance the capability of CBP to be able to deal with illicit drug trafficking across our borders, and another $300 million for the Drug Enforcement Administration to be able to do its work within the United States at being able to seize drugs as well. And as I mentioned before, these are very determined drug traffickers that are going to find a way to get the drugs into the country. We have the greatest professionals on the face of the earth, but we can always do more in order to give them the tools that they need in order to be most effective against this problem.
Thank you. I'm out of time, and I won't go for another round of questions, but I'd think carefully about that relationship between how many people are coming across and what's underlying the fact that you're going to be intercepting a lot more illicit materials as well. Thank you.
Thank you. Senator Hickenlooper.
Thank you, Madam Chair. Mr. Chester, I wanted to ask a question about pyro. Because even as fentanyl devastates our communities, more is coming in. In Colorado, we're just starting to see pyro, a drug that appears to be 10 times stronger than fentanyl. And I know, Mr. Chester, you've made disrupting the supply of illicit drugs a major focus of your career. And how do illicit drugs like pyro, where do they come from? How does it end up in Colorado? And what is the administration doing to try to intercept supply routes?
Yes, thank you for the question, Senator. And I know in particular I-75 is a major corridor for you, and in the amount of concerns that are involved with the physical movement of drug throughout your state and really throughout the region on that corridor. That particular drug and others like it, and I want to be clear kind of in our characterization here. So you have fentanyl itself, and then you have fentanyl analogs, which are alterations, additions, or substitutions to the base fentanyl molecule, an entire class of substances. And then you have other non-fentanyl synthetic opioids, and that's the nitazene family, and those are others that come up. The reason we see them is for two reasons. Number one of the best accelerants for the production of a new drug is action taken against an existing one. These are profit-seeking enterprises that have very smart chemists who want to market new substances, post them on the internet or on social media for availability, and get people to be early adopters to them. So that's the first that's the first way that you see them. And the second way that you see them is it's generally product placement. They have the available precursor chemicals, they have a chemical formulation they can get on, and they advertise it as having a certain qualitative effect on the body. All of them are illicit, all of them are dangerous, and all of them are available on the internet and on the dark web and to be shipped in either physically into the United States or across our borders through mail and express consignment. The last thing I'll tell you is and I know the Rocky Mountain HIDTA very well. We're very proud of the high intensity drug trafficking areas program that we administer and manage here in ONDCP. It's organized. We've extended the overdose response strategy for the HIDTA program to all 50 states, the Virgin Islands, Puerto Rico, and DC. That brings together drug intelligence officers and public health individuals in order to be able to better understand the environment, identify those new and emerging threats like the one that you just mentioned, and be able to take action on them. And they do very good work.
Great. Well, and thank you for the support of HIDTA. They're very effective. Remarkably effective. Dr. Delphine Rittman, fentanyl's killed 1,600 Coloradans in the last almost 3 years. Just a few months ago, we had a high school sophomore from Durango, Colorado, who died from an accidental fentanyl overdose. We received $23 million, maybe a little more than $23 million for the Substance Abuse Prevention Treatment Block Grants as part of the rescue plan, the American Rescue Plan. As this help goes out across Colorado, do you see, or what specifically do you see as the most effective utilizations of that funding? What are the best investments we can use to try and go after the fentanyl overdose rates? And how is SAMHSA working with states to provide that real-time information and data and technical assistance to get there?
Yeah, yeah. So often what we find is states will use the strategic prevention framework approach to being able to identify approaches and strategies that will work most effectively within their context. So many of the community coalitions will do focus groups, meet with schools, meet with students to be able to develop messaging that's going to resonate with students and resonate with schools. And in some instances, the coalitions will work with schools and students to develop some of that messaging so that it's really coming from students. So I think that's one thing that's helpful, developing messaging that students can take in and that raises awareness about the dangers of fentanyl, to include social media access of fentanyl, as well as just the dangers of fentanyl use. I think another strategy that can help is, working with schools to raise awareness about and being able to identify students that may be struggling with substances or that may be having trouble, and ultimately being able to connect those students to services and supports.
Right, thank you. And I think we're making progress in actually identifying the types of kids that would be likely to experiment. So often, with fentanyl, it seems like so often it's somebody who has almost no experience in drug use. Not always, obviously, but too often. Anyway, out of time. I've got a couple other questions, but I'll file them in written form. Thank you.
Senator Casey.
Thank you, Chair Murray, and I want to thank you for calling this hearing, and I want to thank our witnesses for their testimony and for the expertise they bring to bear on this awful fentanyl crisis that has consumed the country. Pennsylvania is third in a category we don't want to be third in overdose deaths. Pennsylvania had 5,438 deaths in 2021 alone. That's one death every 2 hours. And of course, just like in so many other places, fentanyl is the dominant opioid. So it's consumed so many families, so many communities. Like Chair Murray, I'm very concerned about the rise in fentanyl-related overdose deaths in adolescents who, because of their stage of development, are more vulnerable to opioid use disorder. This is particularly the case when a young person has a mental health condition like ADHD, depression, or anxiety, which too often goes undiagnosed and untreated. So I'll start with Dr. Delphin Rittman. Can you speak to two things? Number one, the relationship between opioid use disorder and other mental health conditions. And number two, how timely mental health care for young people can help prevent opioid misuse.
Yes, thank you for that question, Senator, and for all of your work and advocacy in this area. We know that for some youth as well as adults, use of opioids or other substances is connected to, for some individuals, mental health challenges. And so to the extent that services and supports are, and we talk a lot about this, that we're able to take a co-occurring approach, that services and supports are able to address both mental health and substance use challenges. But that's important also in terms of identification. We do have a program called, for short, it's the Youth Family Tree. And what that program is about is early identification of youth that may be struggling, youth as well as transition age individuals and other members of families. It's a grant that takes a community-based approach, a family-based approach, and really uses multi-system approach to be able to identify, do early identification, but also early connection to services and supports such that the addiction doesn't progress. And so I think that's one area that is an important area of work. In fact, that grant is up for authorization, so certainly appreciate this committee's commitment to that area of work. There's also work in terms of, being able to ensure access. You'd mentioned the piece around ensuring that there's timely access to services and supports. And so I think that's an important part of the system of care work as well. ensuring that whether it's a school system or whether family members, that there's awareness around how to access and connect students or families to services and supports.
Thanks very much, Doctor. And I wanted to turn to Carol Johnson, with whom I worked on the Aging Committee. It's great to see you again, I guess twice in a week. But Carol, I wanted to make reference to both screening and access to medications for opioid use disorder, which of course are not yet meeting demand. And we know there are wide gaps in the workforce that are caring for adolescents. I have a bill with Senator Cassidy to support cross-training of the pediatric healthcare workforce to address mental health and substance use disorders. Given the serious threat of fentanyl to young people, we can't afford to miss any opportunity to screen adolescents for these disorders. How do we increase opioid use disorder competency in the pediatric healthcare workforce?
Thank you so much, Senator Casey, and thank you for your leadership on this issue. We think this is critically important, making sure that we create sort of norms and standards in the healthcare workforce, that primary care sites, pediatrics offices, primary care physicians, our community health centers are places where our clinical workforce is trained to identify mental health and substance use disorders, and where appropriate, be able to help begin treatment. And so that's why we're committed to this work. We appreciate the progress that we've made with the Pediatric Mental Health Access Program, which has helped us be able to bring mental health expertise directly into pediatricians' offices. But we want to continue to look for ways to grow the capacity of the primary care workforce and pediatricians to address substance use disorder directly.
Thanks very much. Thanks, Chair Murray.
Senator Rosen.
Thank you, Chair Murray. Really appreciate holding this very important hearing today, and of course the witnesses for all of your work in this area. And so, like so many of us, we're just so worried about our communities and the overdose disparities, especially in Nevada and our Latino communities. The synthetic fentanyl crisis has gotten worse in recent years in Nevada. It has unfortunately disproportionately impacted our growing Latino population. In fact, between 2019 and 2020, drug overdose deaths amongst Latinos in Nevada increased 120%. And the proportion of those involving fentanyl increased 135%, the highest among any demographic group. And so compounding this problem is a lack of awareness in our Latino community about resources, including harm reduction strategies, as well as a shortage of substance abuse disorder providers, particularly culturally competent Spanish-speaking providers. So Dr. Delphin Rittman, what kind of targeted community outreach is SAMHSA doing to ensure Latino communities, not just in Nevada, but across the country, have access to evidence-based substance use disorder resources to help curb addiction, including those harm reduction strategies?
Yeah, thank you for that question, Senator Rosen. And so this is an area that is a priority for SAMHSA. It's certainly a priority as well within the Secretary's overdose prevention strategy, or it's one of the cross-cutting areas that is equity. And so, you know, one of the things that we do is we fund the Hispanic and Latino Addiction Technology Transfer Center. What that center does is it provides a broad range of training and technical assistance to providers across the country. That helps to ensure that those providers are able to implement culturally responsive services that meet the needs of Latino individuals and diverse groups. And so that training and TA is available across the country. Another area of work we have through our Office of Behavioral Health Equity for our new grantees, and actually previous grantees as well, although we've strengthened this program, we now do disparity impact statements. And so grantees have to identify disparity populations that they may be serving within their region or area, and then identify how that grant will be used to address disparities among those individuals or groups where disparities exist. And then what we've increased is we've now increased and will be increasing the technical assistance to grantees to ensure that they have the resources and support that they need in terms of addressing the needs of diverse groups. So we're excited about that program. We think that will make a real difference in terms of working across our grant programs to help them to be able to identify disparity populations, but also address those disparities as well, to include among Latino individuals.
Well, that's great that you're doing that, but we know that you need the resources, and that means the workforce. And so while SAMHSA's Minority Fellowship Program, you have made strides in increasing provider diversity and boosting cultural competency in behavioral health. Data suggests that people of color still only constitute a significant minority of the substance abuse disorder workforce. So again, Dr. Delphin-Rittman, as a committee seeks to reauthorize and enhance SAMHSA programs this year, I really want to see how we can expand and improve on these minority fellowship programs to bring people into the workforce to ensure we're attracting and retaining these providers, mentoring the next gen of them, and they can better serve the trust of Latinos, of course, all of our minority populations, underserved populations across the nation.
Yeah, thank you for that. And that is a program, well, for one, I can say that's near and dear to my heart. I went through the fellowship program 90 to 93 so one thing we're doing to expand that program is to increase the number of individuals that can go through at the master's level. There are doctoral level fellowships that are provided. I went through the doctoral program, but now we're increasing the master's level. That will help to increase the numbers of individuals that are able to begin practicing and begin working in the field sooner. So we're real excited about that. And we know the program's coming up for authorization. That's some of what we'll use those resources for. Other programs we have are around working with HBCUs and Hispanic serving institutions as well, around attracting individuals to the behavioral health professions who may be considering behavioral health or may be interested in behavioral health. And so that is an additional program that works to increase the numbers of individuals from diverse populations that are entering the behavioral health fields, or individuals interested in working with diverse populations as well.
Thank you. I think my time's expired. Thank you, Madam Chair.
Thank you. Senator Kane.
Thank you, Chairman, and thank you to our witnesses for being here today and for your important testimony. So my states, like others, I've heard each senator talk about the tragedy of this in their states. There were 2,656 overdose deaths in Virginia in 2021. It was a 15% increase from 2020. And fentanyl was responsible for 77% of those fatal overdoses. So we're all grappling with this, and I appreciate the testimony, and colleagues of mine have asked many questions that I was going to. I wanted to ask a question about a strategy to deal with this issue, Dr. Delphin-Rittman, that we've talked about before. The last time you were here, I asked a question about connecting incarcerated individuals to treatment services, and in particular about drug courts. You shared information from SAMHSA's drug court program, and those are programs, most of us have them in our states, work to divert individuals from further involvement with the justice system into behavioral health treatment that is more likely to lead to a successful outcome. When I meet with sheriffs in Virginia, I always ask them this as the opening question: what percentage of people in your jail shouldn't be there? I don't have to describe my terms. I don't have to define what I mean. They know what I mean. They know that I'm asking, well, what percentage of people in jail aren't really bad people, they're not really crooks, they're not criminals, but they're people with substance use issues that have either been diagnosed and not treated, or not effectively treated, or in some instances, never diagnosed. I've never had a sheriff give me a number less than 40%. And often sheriffs give me numbers 50, 60, 65%. Since 2017, Virginia has received 4 SAMHSA-supported grants for drug courts, one in Lynchburg, Harrisonburg, Richmond, and Abingdon in far southwest Virginia. And I've been to some of the drug courts to talk to them about what they do. I've been to some graduations. In fact, I've been to 2 graduations in the last couple of years. In one, the drug court program was started by a local circuit court judge whose child had died of a drug overdose, and that led her to spur the effort to start it. And in the other one that I went to, one of the probation officers who works with the drug court program came up to me and said, and this is my 2nd graduation this week. And I said, I thought this county only had 1 program going on at any one time. And he said, we do, but my first graduation was my son graduated from a drug court program in another county.
And here's the one where I'm the probation officer, and I'm here because I'm proud of my graduates. Talk a little bit about the effectiveness of the drug court programs in SAMHSA. There's funding issues. Do we have enough funding to operate them? I happen to believe the monies we invest in these are some of the best investments we make. But if you would, Dr. Delphin-Rittman, talk about drug court programs.
Yes, thank you for that question, and just for all your work in this area. I mean, what we find and what we know is that drug court programs, they make a difference. They make a meaningful impact in people's lives. That it's an opportunity to reduce further penetration into the justice system for individuals that are struggling with substance use challenges. It's an opportunity to connect people to evidence-based services and supports, to include medication-assisted treatment, and to really change the trajectory of an individual's life because they're able to get that treatment that's critical. As you know, we also do in-reach programming.
Yep.
And so the in-reach programming is for individuals that are connected or further along and maybe before release, whether it's from jail or prison, we work to connect them to services and supports to include buprenorphine if necessary. In fact, right after this hearing, I'll be flying to the national annual meeting of drug court professionals, and we'll be doing a series of meetings with different court groups related to their work. This is vital life-saving work, and this program is coming up for reauthorization as well. So certainly appreciate the committee's commitment and interest in this area.
Please pass on, as you go out and talk to drug court professionals, the respect that we have for the work that they do. Here's a question dealing with fentanyl coming into the United States from abroad. What can you tell us, particularly those with the National Drug Control Office, what can you tell us if there's a pie chart? Some come by mail, some people smuggle over the border, some maybe come around the borders. But I understand that huge percentages of the fentanyl that come into the United States come in across our ports of entry in vehicles because we only inspect one out of every however many vehicles. Cartels figure they can play the odds and they can actually just smuggle it right across the border through ports of entry. Can you share what the data is about that?
Yes, Senator, and it's an understandable question, but I'm afraid it's an unknowable question because the only thing that we can calculate is what we see and what we find, right? But your characterization of vehicles is correct, but I think for a different reason. Our Customs and Border Protection do have the ability to be able to do non-intrusive detection that's very impressive. I was down last fall in El Paso, and the non-intrusive detection capability that they have is very good. But more importantly, those ports are manned with incredibly experienced agents who can pull a vehicle into secondary just based upon, I've seen this before, just based upon intuition. And they also have heuristic models and algorithms that can determine the right time to pull folks into secondary. So there are a lot of reasons why someone get pulled into secondary. But your characterization of drug traffickers is absolutely correct, because a drug trafficker can send 10 vehicles across knowing that 2 may get pulled aside, but that's just built into the business model on the amount of profit and knowing that the remainder are going to be able to get through. That's the challenge that we have. And even if we were able to reduce that number to C7 and only 3 get through, drug traffickers in pursuit of profits are going to find other ways in order to be able to circumvent that and get the drugs into the country. So what we do by looking at it really in a more holistic fashion is to determine when we see changes in the environment and how quickly we can surge in order to address that change as well. And that's why when we describe it as a dynamic environment, that's what we mean by that.
Well, I'm over time, but Madam Chair, to me, what that suggests is if any of our efforts on the enforcement side just lead creative people who want to make profit to figure out another way to do it, then ultimately you've got to tackle this on the demand side. And so that's prevention, and that's the kind of things you've been testifying to. And if we don't tackle it,
Thank you. That will conclude our hearing today, and I want to thank all of my colleagues, and especially I want to thank our witnesses today, Mr. Kemp, Dr. Delphin-Rittman, Ms. Johnson, Dr. Jones. Thank you for a very thoughtful conversation on such an urgent crisis for all of our communities. If there's one thing we take away from today's conversation, I hope it is that our communities can't wait. They need urgent action from the administration and from us in Congress to disrupt the supply of dangerous illicit fentanyl, to support those on the front lines of this crisis in our communities, and especially to connect people with the prevention, the treatment, and recovery support services that we know saves lives. That's why it is really important to me, more important to me as ever, that we can advance a bipartisan package that makes meaningful progress on these issues. And I hope that all of my Republican colleagues agree, and that we can continue our process negotiating a very robust mental health and substance use disorder bill that will support the programs we have seen make such a difference and provide additional tools and resources to tackle the new threats and emerging challenges in this space. For any senators who wish to ask additional questions, questions for the record will be due in 10 business days, August 9th at 5 p.m., and the committee stands adjourned.